Hey everybody, welcome back to the ECG of the day. My name is Reid, and don't forget that you can download this PDF down from the description below and follow along. And don't forget to like this video and subscribe to the channel if you enjoy the content. So let's go ahead and get started. So the first thing I like to do with all rhythms is look at the forest. And so I pick a rhythm strip here and kind of figure out what I think is going on out the gate. And so I see I've got a narrow complex rhythm. That seems to be pretty irregular. There's some small variations in the rate that is likely due to like a sinus arrhythmia, but it seems like it's pretty regular and it's narrow complex, which makes me think that it's coming from somewhere within the AV node or higher, right? Because narrow means it's taking that nice His-Purkinje system. And I just glance in front of my QRSs and I see that there seems to be P waves in front of those QRSs. And so let's evaluate kind of how the atria is acting right now. And I see my P waves, the morphology is upright in lead 1, and it is upright in AVF. So it tells me that these P waves are coming from the sinus node, so that's good. Sinus node has a pretty predictable pattern, and so if we calculate the rate of our sinus rhythm, we'll find a QRS that lands kind of on a solid line, and we count 300, 150, 100, that would be 75, so maybe 80 beats per minute. So we've got a sinus rhythm at like 80 beats per minute or so. The next thing that happens in our conduction pathway is the AV node captures that signal, and that's displayed as the PR interval. And so I can measure my PR interval, and we want the PR interval to be in between 120 and 200 milliseconds. We know that that is 3 to 5 small boxes, and so that PR interval meets that normal criteria. But I know that we need to kind of scan through and make sure that every P wave conducts to a QRS, that there are no P waves kind of hidden in between, like on top of a T wave or an SD segment, and make sure of that. So if you scan through this strip, you see that doesn't seem to be the case. So every P wave that arrives to the AV node, every time signal gets to the AV node, here, the AV node conducts that signal down, and we get a nice narrow QRS. So that's reassuring. Let's take a look at what the QRS itself is doing, right? My QRS morphology, we said if we measure the width of the QRS, we said that the QRS was within 120 milliseconds, which is normal. My QRS complex is upright in lead 1, and I would say it's isoelectric in AVF. So it tells me it's perpendicular to AVF but towards lead 1, so axis is kind of that way at 0 degrees, which is within our normal limits. It's not markedly deviated to the left or the right. And you can see if I look for R wave progression throughout the precordium, I really don't have great R wave progression, right? It starts to grow at V4, but it transitions at V5. So we would say we have a late R wave progression. Remember that R waves should be growing as they wrap from V1 towards V3, V4, because V3, V4 are kind of sitting over that thick left ventricle, right? And so there's some reasons why we can have late R wave progression. We can look at that later. And then lastly, my QT interval. Sometimes I'll just like to eyeball it. I'll take an R to R interval. I'll find the midway point between the two of those, and I'll make sure that my T wave is done and terminated by that point. And that should be a pretty solid QT interval, right? No problems. So the last thing for me to do is to look for any pathological Q waves or ST or T wave changes that might make me think of either previous or active myocardial ischemia or infarction. So the first thing I do is I notice that in the inferior leads, it's kind of the first place that my eyes go, right here in especially leads 3 in AVF, I do notice that there seems to be some ST depression, right? Here's my baseline, some depression, right? Some kind of little bit of inverted T waves, or we would say kind of downsloping ST depression. So we've got some ST depression in my inferior leads, which my inferior leads are here. So my eyes immediately go to what is reciprocal to these inferior leads, which is AVL. And I want to see, is there ST elevation in AVL? And when I look at AVL, what I notice is that these are little QRS complexes, but these T waves are very hyperacute, right? A normal T wave is kind of like flat and then upslopes a little bit. And the area under the curve is not very much. But these ones are more hyperacute, and there is a little bit of ST segment elevation from baseline. So hyperacute T waves is we would say a kind of like a STEMI type of equivalent sign, right? It's a sign of occlusion. That tells me that there's potentially occlusion, especially in the setting of what we now understand is reciprocal depression in my inferior leads. So we've got some involvement, maybe to a lesser degree here in lead 1, right? Lesser degree of hyperacute waves in lead 1 compared to AVL. Right, T waves proportional to the QRS, right? It's important. And then when I scan through my precordium, I see that I've got these deep pathological Q waves throughout leads V1, V2, V3. So we have pathological Q waves in this kind of anterior, maybe anteroseptal region. And I've also got a little bit of ST segment elevation here in V2, which I wonder if this has to kind of anything to do with maybe some evolving infarction in the anterior leads, right? Especially in the setting of these deep pathological Q waves, that tells me that maybe this is a late kind of ischemic change that we're seeing in these anterior and anteroseptal leads, because we know that usually it presents initially with ST elevation, but over time, as myocardium infarcts, you get these deep pathological Q waves because we cannot conduct tissue towards that region, and so it's a negative Q wave. So maybe this is kind of an evolving anterior infarction. So this is a hard case, but luckily I can give you the outcome. This patient went to the cath lab, and what did they find in the cath lab? They found 95% stenosis of the left anterior descending, which explains the findings in V1, V2, and V3. They also found 95% stenosis of the left circumflex, which explains our findings in lead AVL and a little bit in lead 1, right? The high lateral leads, which the left circumflex usually kind of feeds. So it's a pretty interesting case, right? Where you have a case of multivessel disease causing myocardial infarction kind of at the same time, right? So you wonder maybe what the underlying process was that contributed to this person's acute presentation. So when you put this all together, what do we have? We've got a sinus rhythm at a rate of 80 beats per minute with poor R wave progression, late R wave progression through the precordium that I believe is best explained by these high lateral hyperacute T waves and some acute, subacute, late ischemic changes maybe that we're seeing in the anteroseptal leads. So I hope this helps. If you have any questions about this rhythm, feel free to ask away down in the comments below. And if not, thank you so much for supporting the channel and watching these videos. Alrighty, have a great day. See you on the next ECG video.